So this is who I am, professor, and I work at the University of Pennsylvania School of Medicine in Philadelphia. And my other affiliation is with the Philadelphia Department of Veterans Affairs, where there's a large Parkinson Center called the Podrick. And for the past 20 years, I've been seeing patients with Parkinson's disease almost exclusively from a clinical standpoint and a clinical research standpoint. And as a geriatric psychiatrist, I focus on the psychiatric and cognitive aspects of the illness. I don't manage the motor symptoms of Parkinson's disease. I leave that to the movement disorders neurologists that I work with. So I focus just on these other areas. See if I can get to the next slide. It seems to be a slow. Maybe if I do it down here. Yeah, this just doesn't seem to be working. There we go. It's just slow, so we'll see how it goes. So these are my disclosures in terms of research funding or support or honoraria or licensing fees, and it's all related to the work that I'm going to discuss today. Here, it seems to be working okay now. The goals of what I'm going to present, and again, I think I can do this in a half hour, so we have sufficient time for comments, questions, is to provide an overview of the neuropsychiatric aspects of Parkinson's disease, how they present, risk factors, assessment, management. I can't really go into much detail, so if people have specific questions at the end, we can cover things then. It's thought, and I believe this to be true, that non-motor symptoms for many patients may have the greatest impact on their quality of life, function, and also caregiver burden at this point in time. And that's partly because so many improvements have been made in the management of the motor symptoms of Parkinson's disease over the past 50 years since levodopa was introduced, that what's left for many patients are sometimes significant non-motor symptoms, as we call them. If I was going to cover the main disorders, it would be the ones in blue, and those are the ones I'll try to cover today briefly. So depression and anxiety, which are sometimes lumped together and called affective disorders, psychosis, impulse control disorders, and cognitive changes. And of course, there's other things as well, disorders of sleep and wakefulness, problems with motivation or apathy as it's called, and other changes that can occur. So some of the caveats when talking to patients, particularly or loved ones about this topic, is that many Parkinson's patients have no psychiatric symptoms or cognitive complications. So it's not that everyone gets this. They're not the fault of and do not represent weakness in a patient. They're many times linked to the neurobiology of the illness. The Parkinson's patients in general cope extremely well, given that they have a chronic, often progressive and sometimes disabling disease, at least in the later stages. And family members and caregivers are in general remarkably supportive and understanding of all that patients go through. That's been my experience working with patients, and typically I'm seeing them with somebody, a spouse or an adult child. The illness may have, for some people, unrecognized beneficial effects even. Not that you wish that you had the illness, but some of the medications that are used to treat the illness can have some mood enhancing benefits. There may be enhanced creativity for some patients on particularly one class of medication, dopamine agonist. And we've done what's called qualitative research, asking patients and their loved ones kind of open-ended questions about the impact of the illness. And people do report some positive consequences, such as personal growth or a more satisfying marital relationship in some ways. So if we go into the individual disorders now, depression is the one that's been longest recognized and most well studied. So it's easiest to start with that. And I titled this slide the Robin Williams effect because the issue about what causes depression in Parkinson's disease came to mind when he took his life years ago now, because he had been recently diagnosed with Parkinson's disease, ultimately was re-diagnosed after autopsy with Lewy body dementia. But he had been treated for psychiatric illness prior to his onset of Parkinson's. He was then treated with medications for the Parkinson's disease. So people wanted to know, was it the illness that caused him to take his life? Was it the biology of the illness that caused him to have it? This outcome? Was it the psychological impact of being diagnosed with this? Was there something else going on? Were the medications playing a role in it? And we're not able to, as psychiatrists, to differentiate these possible factors. We're not able to look into the brain in that way. So we do know that there's huge psychological impact of being diagnosed with an illness such as Parkinson's disease. It's a life-altering event. There's no way around that. And there's challenges every step of the way from diagnosis onward. And maybe particularly so for people that are younger when they have the disease onset in their 40s or 50s, people that are still working, have a career, raising a family. It's even more difficult for those people. And then there's the biology of the illness that can play a direct role for many of the psychiatric and cognitive aspects. The brain regions and chemicals, what we call neurotransmitters, that are affected by Parkinson's disease are those that are responsible for mood regulation in this case. And that may be why we see increased rates of depression and anxiety in what we call the prodromal phase of Parkinson's. So that's before people even know they have the illness. In the several years or so leading up to the illness, there's higher rates of depression and anxiety. So that could only be linked to something that's going on in the brain prior to the motor symptoms. But at the end of the day, these factors, psychological, biological, are intricately linked, and we can't really separate them, and it doesn't really help us guide treatment in any way either. In terms of risk factors, there is a higher frequency in females and those with cognitive impairment, but that mirrors what we already know from the general population as well. That's not specific to Parkinson's disease. So if you look at the 5 factors that most predict depression and Parkinson's disease, very little of them have to do with Parkinson's disease. It has to do with older age, female sex, having a prior history of depression, family history of depression, and other medical conditions, which is true with the general population. In terms of deep brain stimulation, because that's an important topic, more and more patients with Parkinson's disease are administered DBS or deep brain stimulation, about 15% now. And in general, depression severity or symptoms improve on average, but it can be variable. It seems that the people that have psychiatric problems prior to deep brain stimulation are the ones that may have problems afterwards as well. And there's 2 main locations you may be familiar with for deep brain stimulation in the brain. One is called the STN or subthalamic nucleus, and the other is called the GPI or globus pallidus interna. And there's some evidence that people that have a depression history or just in general may do better with mood after the surgery if they have the GPI settings or location as opposed to STN. When you're diagnosing depression and Parkinson's disease, as a psychiatrist, I use what's called the DSM-5. It's a diagnostic and statistical manual. And if you look at the diagnostic criteria in DSM-5 for major depressive disorder, it gets tricky because 5 of the 9 symptoms, and I list them here, are common in Parkinson's disease, regardless of whether you have depression. So problems with too little or too much sleep, appetite changes, typically Parkinson's patients lose weight over time, slowness, fatigue, changes in concentration and thinking. So any Parkinson's disease patient would recognize those symptoms regardless of whether they're depressed. So how do you know whether to attribute it to depression or not? And we don't really have a great way to sort that out. In general, we try to give the patient the benefit of the doubt, so to speak, so attribute it to depression, so they're not being denied treatment for something that may improve with antidepressant treatment. But that's not a very satisfying way to sort the issue out. When I see people clinically, I do try to emphasize mood, how the person's feeling inside, feeling sad, feeling down, unhappy, and also what we call the cognitive symptoms of depression, whether the person feels guilty, helpless, hopeless. So those, some people think, may be more specific to depression and not just the other changes that can occur in Parkinson's disease. In terms of treatment, when I used to first give talks on depression, years ago, there was very little positive evidence or evidence from studies that were positive. And that's changed over the last 5 to 10 years. So there's now been multiple positive randomized controlled trials, as they're called, for the following medications: an older antidepressant class called tricyclic antidepressants, and one in particular called nortriptyline. One of the newer classes of antidepressants, SSRIs, selective serotonin reuptake inhibitors, and the one in particular in this study was paroxetine, or Paxil is the other name for that. Then serotonin norepinephrine reuptake inhibitor, SNRI, is another closely related antidepressant class, and there one called venlafaxine, or Effexor, was positive. And then finally, there's actually been an antidepressant study in Parkinson's disease using a dopamine agonist, pramipexole or Mirapex, not as a treatment for the motor symptoms of Parkinson's disease, but for depression in Parkinson's disease. And all of these trials that I just mentioned were positive. So these are all available treatment options for us for patients with Parkinson's disease who are depressed. There's also been a few recent positive studies for psychotherapy or counseling, specifically cognitive behavioral therapy, that have shown benefit for both depression and anxiety symptoms in Parkinson's disease. So that would be the non-pharmacological end of things. In terms of tolerability, because whenever we're talking about prescribing psychiatric medications in Parkinson's disease patients, you want to know how are they going to tolerate it in terms of their Parkinson's symptoms. So although there is literature suggesting that those SSRIs that I mentioned before can worsen Parkinsonism or tremor, the studies, the randomized controlled trials I referred to before, showed very good tolerability overall from a motor standpoint. And that's been my clinical experience as well, is that most Parkinson's patients can tolerate antidepressants, and about 20 to 25% of Parkinson's disease patients are on an antidepressant at any given time. Another issue that comes up when prescribing an antidepressant in this population is if the person happens to be taking what's called an MAOB inhibitor, or monoamine oxidase B inhibitor. The two most common ones are in the past selegiline, and now more commonly rasagiline, also known as Azilect. And the reason for that is because it can boost the level of serotonin in your body, this MAOB inhibitor, and that antidepressant is also doing that, is also having that effect. So you can get an overload of serotonin and the development of something called serotonin syndrome. And usually the pharmacy will raise a red flag about this possible combination, let the patient know, let the prescribing physician know. We had a chance to look at some data from randomized controlled trials, and it seems to be, if it occurs, a very rare effect. And I've been doing this for 20 years, and I haven't actually had a patient that I've known of that's had this serotonin syndrome effect. But that doesn't mean it doesn't happen. It just may be uncommon. And if it happens, it's a medical emergency or urgent situation, because there can be mental status changes, temperature, rigidity. So somebody really needs to get prompt medical attention if that were to occur. We still do commonly prescribe, though, MAOB inhibitors and antidepressants in Parkinson's disease. Anxiety, there's not much to say, and I wish there was more to say, because it's a very significant problem for many Parkinson's patients. Most patients with an anxiety disorder have depression and vice versa. My clinical experience is that anxiety is often a more disabling or upsetting symptom to patients than depression, because they can have anxiety attacks and be very fearful, which is a very distressing feeling. And they can also have physical symptoms. If you have an anxiety or panic attack and your heart's beating fast and you get short of breath, and patients can feel like they're going to die sometimes or having a heart attack. So it can be a very upsetting symptom to have. The presentation of anxiety in Parkinson's disease is either generalized anxiety, which is anxiety symptoms day in and day out, over worrying, excessive worrying, social anxiety symptoms, so fearfulness of leaving the house or fearful of being in public, where one may be embarrassed by their Parkinson's symptoms. And then finally, anxiety or panic attacks, these very discrete, time-limited episodes where somebody feels, again, like they're going to die or something terrible is going to happen, because they're so intensely anxious. Some of those are timed with what we call off periods, when patients' Parkinson's medications, particularly their levodopa, is wearing off over time. So these are often patients that are on higher doses, have had the illness for a while, taking levodopa frequently, and they have these periods where they're on after they're taking the medication, but then periods where they're off as it's wearing off. And these off periods can be accompanied by intense anxiety and other symptoms sometimes. In terms of treatment, there's been no good or adequate treatment studies for anxiety specifically in Parkinson's disease. We use newer antidepressants, some of the ones I mentioned already, because they're all FDA approved not only for depression, but also for anxiety disorders as well. But sometimes that's not sufficient and we have to use more potent anti-anxiety medications, and those would be what are called benzodiazepines. And the most commonly used, I would say, in Parkinson's disease are lorazepam, also known as Ativan, alprazolam, which is Xanax, and clonazepam, which is Klonopin. The last one, clonazepam, is used primarily at bedtime to treat another disorder, rapid eye movement sleep behavior disorder, also known as RBD, and I'll say a little bit about that at the end. Lorazepam and alprazolam tend to be used more during the daytime hours. But you have to be aware of cognitive side effects, sedation, and changes in balance and gait with these medications. And those are particularly potentially problematic side effects for a Parkinson's patient. So we tend to start at low dosages. When we're using them or I'm using them, they can be used on an as-needed basis, what's called PRN, or on a scheduled basis, depending on the frequency and the severity of the symptoms. My clinical experiences have been that sometimes patients are experiencing some mild cognitive changes, problems with attention or concentration or problem solving, and that those cognitive changes are what's making them intensely anxious, and that sometimes cognitive enhancing medications may help with that. So the next disorder to cover is psychosis. And psychosis to a psychiatrist means hallucinations or delusions. What we've learned about hallucinations in Parkinson's disease over the years is that they don't only occur in the visual domain, but also in the auditory, olfactory, and tactile as well. So not only can people see things that aren't there, but they can hear, smell, and feel things that are not there as well. Illusions are when somebody misidentifies an actual object that's there. And there's also something called passage and presence phenomenon. So passage is the sense that there's something in the periphery of one's vision that's moving, and presence is the sense that there's a person in the periphery of one's vision when there isn't. Delusions are fixed false beliefs that can occur in a subset of patients. They seem to be less common than hallucinations and perhaps associated with more severe symptoms, more severe cognitive impairment. And they're typically what we call paranoid in nature. So persecutory ideation that one's spouse is being unfaithful or that there's intruders in the house. And if severe, these symptoms can lead to institutionalization. It's been shown to be a risk factor due to the agitation sometimes associated with them. They can impair one's sleep, and they can also lead to great caregiver burden. So that's the reason these symptoms are so important or significant. Some of the factors associated with psychosis include both increasing severity of the illness itself, but also the Parkinson's medications that are used to treat the illness. And as I mentioned before, the more advanced one's cognitive impairment is, the more likely they are to have psychosis and severe psychosis. There may be visual changes. Parkinson's patients do experience a range of visual impairments such as double vision, decreased color acuity that may be associated with visual hallucinations. So it seems that there's a complexity to what causes these symptoms in Parkinson's patients. And there's 3 brain chemicals or neurotransmitters that are linked with it: dopamine, serotonin, and a third one called acetylcholine. There's evidence for all 3 of these being affected in Parkinson's psychosis. So what does one do when faced with the management of these symptoms? So if the symptoms are minor, you don't have to do anything. You also want to make sure the person's not having an acute medical condition that might also cause hallucinations, such as a urinary tract infection or a respiratory infection. Once all that's been ruled out or addressed, the Parkinson's doctor will often try to start making adjustments to Parkinson's medications, to decrease dosages, to remove medications, because Parkinson's patients often end up on multiple medications at a time. And this is the recommended order for them to be discontinued. And by the time I see somebody, they've often had all of these other medications at the top stripped away, and they're just taking the carbidopa, levodopa, and that's what they try to manage the Parkinson symptoms with at that point. Sometimes that's not sufficient, and we've got to resort to using antipsychotics, or what I label as AP here, abbreviate as AP. So there, the trick is trying to balance the benefits, the antipsychotic benefits, improvement in hallucinations and delusions, with a potential risk, which include worsening Parkinson's symptoms. So there's several antipsychotics that are most commonly used. The most commonly by far is called quetiapine or Seroquel, and that's probably represents 80 or more percentage of all prescriptions for Parkinson's antipsychotics. And there's a wide dosage range that can be used. The problem with quetiapine right now anyway is that all the clinical trials have been negative or inconclusive, so we don't really have a very good scientific base on which to recommend this. Clozapine, another antipsychotic, an older one, has been shown to work at low dosages in a couple of clinical trials. The issue with clozapine, though, is that you have to have frequent blood drawing to monitor for a blood side effect. And that is enough to prevent many patients and clinicians from wanting to prescribe it. So clozapine is rarely used. And then as of about 3 years ago, we have a newer antipsychotic approved specifically for Parkinson's disease psychosis called pimavanserin or Nuplazid. And that affects the serotonin system specifically, but not dopamine. And because it doesn't block dopamine, there's less concern about worsening of motor symptoms. And there's been a positive study, primary study that led to its approval. There's since been a study in Parkinson's and other dementia disorders, so Alzheimer's disease included, that showed benefit. And then there's this controversy that arose a few years ago about whether there's an elevated mortality risk associated with this medication in Parkinson's disease. And we had been involved in some research. I'm not looking at that medication because it hadn't been around for long enough, but other antipsychotics like quetiapine. And it seems that all of the antipsychotics may be associated with some kind of an small increased risk for mortality in Parkinson's disease, as they've already been shown to have an increased risk in Alzheimer's disease. So it doesn't seem specific to Parkinson's. It happens in other similar disorders, and it doesn't seem specific to pimavanserin. It seems to be across all antipsychotics, but we still do need to use them sometimes for for clinically significant symptoms. So that's 2 of the disorders. Now up to impulse control disorders. So there's 4 disorders that are reported to occur in Parkinson's disease, or primary disorders. There's other ones as well, but the 4 primary ones are gambling, sex, buying, and eating. And these are behaviors that are atypical for the person, different than how they used to be before the Parkinson's disease. They only seem to occur in the context of the Parkinson's disease and its treatment, the medications. There's a couple of related disorders that I won't really go into, but one called dopamine dysregulation syndrome, where somebody's actively misusing their medication, trying to get higher dosages of medications such as levodopa than the doctor is prescribing because they feel good when they're taking the medication and feel bad as it's wearing off. So they keep trying to go into an on state by taking more and more of the medication. About 15 to 20% of patients on a dopamine agonist may experience this problem over time. So it's not uncommon, I would say. It's one of the reasons dopamine agonists are not used as commonly as they used to be. The medication class most strongly associated is dopamine agonist, although some patients develop it just on levodopa, carbidopa levodopa, and that's if they're on higher dosages particularly. If somebody has one impulse control disorder, there's about a 25% chance that they have a second one. So you have to ask about all kinds of different behaviors, unusual behaviors. And the other thing is you can't assume that if you've been on the medication for a month or 6 months or a year, that you're out of the woods, because when we did a study before, we found that the median or middle time, average time for onset of these symptoms was 4 to 5 years after starting the medication. So you have to constantly monitor, be vigilant about these symptoms. So I mentioned the dopamine agonist is a risk factor. Higher dosages of levodopa. A couple of other treatments have also been associated, although to a lesser extent, amantadine and possibly even rasagiline. It seems that younger age is associated, younger age of Parkinson's onset is associated with this. And there's some sex differences. Males are more likely to have sexual behaviors. Females are more likely to have buying and eating behaviors. So what do you do to manage this? Well, you can modify the Parkinson's medications. That's the ideal option. So that usually people try to come off or go to a much lower dosage of their dopamine agonist and may go to a higher dosage of the levodopa to offset that. The problem is we've now recognized that there's a withdrawal symptom that can occur for some patients called DAWS, or dopamine agonist withdrawal syndrome. And it's a very uncomfortable physical and psychological state when patients come off of the dopamine agonists, and sometimes they have much difficulty tolerating that. There's some preliminary evidence that maybe longer acting oral medications, so ones that are taken once a day as opposed to multiple times a day, or alternate delivery systems. There's retigotine patch, so it's put on your skin as opposed to orally, also long acting, may be associated with less impulse control disorders. It's not clear, but a possibility. Deep brain stimulation, usually successful, allows a patient to be on a lower medication dose after the surgery, and that typically helps with these symptoms resolving or lessening. We use psychiatric medications commonly, but with limited support. And we had done one study with a particular medication called naltrexone. It blocks the opioids in the brain, and naltrexone is actually FDA approved for the treatment of alcoholism. And in this study, we tested it for impulse control disorders and in Parkinson's, and it did show on a rating scale anyway that there was improvement in symptoms compared with those patients that were on the placebo or fake pill. And there's also a psychotherapy study, cognitive behavioral techniques, again, that have been shown to be helpful for impulse control disorder symptoms. And then finally, the last main category is cognitive changes. So when we look at cognition, we roughly group people into one of three categories. Either they have normal cognition, mild cognitive impairment, or dementia. So mild cognitive impairment means that the person's experienced or reported some cognitive decline compared with their pre-Parkinson state. They show some level of impairment, typically mild on the testing that we do, the cognitive testing, but yet their function is overall intact, so they're able to live their life day to day without problems, significant problems. Dementia means that there's typically a greater impairment on the testing that we're giving them, and also that there's clinically significant functional impairment, so they're no longer able to function in the same way. We have these confusing diagnostic terms overlapping with Parkinson's disease, and one is dementia with Lewy bodies, or DLB. And of course, I've just mentioned that there's Parkinson's disease dementia, or what we call PDD. It's not really clear how these syndromes are entirely different, but one difference in terms of how they're diagnosed is that Parkinson's disease dementia means that you've had Parkinson's disease established for some time and then developed dementia. Dementia with Lewy bodies means that dementia is the presenting symptom, and you also may have Parkinsonism as well, Parkinson's symptoms. I often get questions about whether somebody who has Parkinson's disease can get Alzheimer's disease as well, and the answer is yes and no. Yes, in terms of it doesn't mean your brain isn't affected by Alzheimer's disease, but we don't diagnose people clinically with Alzheimer's disease once they have a diagnosis of Parkinson's. We just diagnose them with Parkinson's dementia. So I don't know if that's really a clear solution, but that's how it works. What about the risk factors for cognitive deficits in Parkinson's disease? So increasing age, clearly, maybe younger patients, young patients with younger onset tend to do better for a longer period of time, not surprisingly. Increasing severity of Parkinson's, and some controversy, but many studies have shown that males more than females. There's some evidence that if you have less tremor and more other types of Parkinson's symptoms, what are called akinetic rigid, or problems with posture and stability and gait, that may be associated with more cognitive changes. There's some evidence that deep brain stimulation is associated on average with a slight decrease in cognition, or meaningful decrease in maybe 10 to 15% of patients post-surgery. When we look at the cognitive profile in Parkinson's disease and we test people, we point to 5 main domains to try to organize how we test and talk about things. So executive impairment or executive abilities is the abilities you need to plan and sequence and adapt and problem solve, involves concepts. That's your executive abilities. Attention is your ability to sustain concentration over a period of time. Visual spatial abilities are one's abilities to understand things in 3 dimensions or space, so the relationships of objects in space. And the one kind of easy thing to point to in terms of what uses visual spatial abilities is driving. So when you're driving, you're using constantly your ability to judge things in 3 dimensions. Impaired memory, so there's both encoding of new information and retrieval of information once it's been learned. And it's thought that the memory profile or the memory changes that occur in Parkinson's are different than the ones that occur in Alzheimer's disease in this regard. And then language skills is the 5th domain. And those tend to be relatively well preserved in Parkinson's. Sometimes patients do report word finding problems. In terms of treatment, we have a class of medications called cholinesterase inhibitors, first approved for the treatment of Alzheimer's disease, but one of them is also approved for the treatment of Parkinson's disease, dementia, not mild cognitive impairment, but dementia, and that's called rivastigmine or Exelon. The meaningful improvement with this medication is modest, so even though it does have some benefit or effect, it's not typically that robust an effect. It tends to be well tolerated overall, other than perhaps some mild nausea and tremor. There's another major class of compounds also approved for Parkinson's disease, another class, and that has one medication they call memantine or Namenda, and that's also been studied in Parkinson's disease dementia with Lewy bodies. I'd say the effects are mixed, one partially positive study and one negative study for Parkinson's disease dementia. But we do use this medication as well, particularly in patients with more advanced cognitive impairment. So what else can people do while they worry about their cognition or notice changes and are waiting for new treatments to emerge? So cardiovascular exercise is important in maintaining a good body mass index. Cognitive exercise may be enjoyable, potentially helpful, but it's easy to do. So crossword puzzles, games, anything that's intellectually stimulating. Managing vascular risk factors is important because we know that people that have what we call blood vessel diseases, high blood pressure, diabetes, high cholesterol levels, tend to do worse from a cognitive standpoint. So it's important to manage those disorders if they're present. There's a couple of classes of medications that may be associated with worsening cognition in Parkinson's disease. Benzodiazepines, I mentioned before, opiates or pain medications. And then there's a broad category that have anticholinergic properties. And the most commonly used one that somebody may be familiar with would be something like Benadryl that you might take with Tylenol PM to help you sleep at night. But Benadryl and lots of medications like it have these anticholinergic properties that can affect people's cognition and have to be used cautiously. Multiple psychiatric disorders like depression are associated with impaired cognition. So it's not clear if treating those psychiatric disorders helps cognition, but it's important they be treated anyway. A good night's sleep. So people with Parkinson's disease may be an increased risk of obstructive sleep apnea. And I mentioned this RBD disorder before. People that don't sleep well at night tend to do worse from a cognitive standpoint. So getting a good night's sleep is important. And then finally, one specific disorder, orthostatic hypotension, where patients' blood pressure drops when they go from a sitting to a standing position. They've shown that when you test people cognitively who are hypotensive, low blood pressure, they tend to do worse from a cognitive standpoint. And then finally, other disorders in the last couple of minutes and done. Apathy, I mentioned, is a decreased initiation or engagement in activities, speech, and emotion. And this is something that family members in particular tend to complain about when it occurs, because they see their loved ones sitting around and not doing anything, and they recognize there's something that's not right. They might think that the person's depressed, although the patient may not report depression. And we don't really have any anti-apathy treatments, but sometimes we do use stimulants and stimulating antidepressants in clinical care. Daytime sleepiness and fatigue are thought to be distinct disorders, but a big problem for Parkinson's disease patients, just feeling the need to sleep or just feeling physically or mentally exhausted. Again, we understand relatively little about these disorders, whether they're disease-related, medication-related, and understand even less about how to best manage them, but we do recognize that they are a significant issue. And the REM sleep behavior disorder, I'm sure most people have heard about, but that's where somebody verbally and physically acts out their dream during the rapid eye movement or dream phase of sleep. It's not an uncommon occurrence in Parkinson's. It can be disruptive, particularly to the bed partner. The patient often doesn't know that it's happening because they're asleep. It's not to be confused with hallucinations, which are occurring during a waking state. This is all sleeping behavior. And it's often treated with clonazepam, or some people may use melatonin at bedtime. And it seems to be with reasonable success. And pseudobulbar affect is a disorder where people can have spontaneous episodes of emotionality, typically crying, but also laughing. It's not necessarily associated with depression, because these episodes are short-lived and not necessarily associated with a depressed underlying mood. It's just part of the brain changes that can happen with Parkinson's disease. And that treatment is typically antidepressants, or there's actually an FDA-approved treatment for this pseudobulbar affect called Nudexta. It's a combination of a cough suppressant, dextromethorphan, and an antiarrhythmic agent, quinidine. And this is my concluding slide, that from my time doing this 20 years now, yes, Parkinson's disease is a motor disease, but neuropsychiatric symptoms are increasingly recognized as common and important. Comorbidity typically happens with these. So if somebody has one disorder or symptom, they often have more than one. They seem to be associated in many cases with disease-related brain changes. The Parkinson's medications and treatments themselves appear to have mixed effects, may lead to some problems, but also help with others. From my standpoint, the psychiatric standpoint, there's clearly still under recognition and under treatment, which is not surprising given that movement disorders neurologists have enough to deal with in terms of the motor symptoms and aren't really trained for this. So that's why we need more people working on the non-motor end of the disorder as well. And clearly we still need a need for new treatments for most of these disorders. We made some advances over the past 20 years, but still room for much more improvement. And with that, I can end the formal presentation, Isabel.